The attack rate is different, we presume, with the coronavirus. And the attack rate is really a measure of kind of the speed of spread. So how contagious is it? How often do folks get it when they're exposed to it? So we suspect that the attack rate might be higher. The most important difference is something we call the case fatality rate, or sometimes referred to as a case fatality ratio, commonly referred to as the mortality rate, the death rate, essentially. So what proportion of folks who get the illness, contract the virus, actually go on and die? So just by contrast, with the seasonal flu, it's 0.1%. And then with this, it's 3.4% all takers. So that's the global rate. So you're talking about a differential of 34 times more deadly that this virus is compared to the flu virus. So that's a 3.4% fatality rate. Let me put that into perspective, because although it is cause for concern, we're not quite at the alarm yet. If you take a look at the case fatality rate for something like SARS, it's actually 15%, and this is in the SARS family of viruses. If you look at MERS, which we had here, when I was the director of health here in the state, that case fatality rate is about 34%. Ebola, 50%, up to 90%. Okay, so that just kind of gives you the continuum. But that said, because this is highly contagious and it's 34 times more deadly than the flu virus, that's really the reason for concern. Last point I'll make on that is that the case fatality or the death rate actually varies with categories. Most people have been hearing there's certain vulnerable folks. That's because their case fatality rate is much higher. I'll give you an example. If you're in your 80s, your case fatality rate is about 15%, as opposed to the overall, which is 3.4. If you're less than 30, it's less than 1 percentage point. It's actually less than a half percentage point. So what we learned is that the older you get, the more you're at risk for dying. In addition, if you have health conditions, cardiovascular disease, for instance, your case fatality rate goes from the average of 3.4 to 10. If you have diabetes, it goes up to 7%, et cetera, et cetera. The case fatality rate helps us to understand how deadly the virus is, but also it helps us to categorize who's in harm's way most, and that's what we're learning. Sure. So here's another area of overlap between the flu virus. It's actually transmitted the same exact way. It is a respiratory virus. It kind of gets into your respiratory air system. That's anywhere from your mouth down into your lungs, your airways. That's kind of where it hangs out. That's how it's transmitted. So when you're sneezing, when you're coughing, when you're talking very colorfully, and these droplets go out of your mouth, then the virus is in those droplets. And those droplets can be aerosolized for a while until they land. They can land on hard surfaces in particular and last for hours to days on hard surfaces, doorknobs, things like that, the copy machine, the microwave in the break room. And so they're transmitted exactly the same way. Someone comes by, they touch a surface, or they walk through that plume of your sneeze. It colonizes their airways, their mucous membranes, and eventually it gets into their body. So they work basically the same way, the seasonal flu and this as well. But again, we think the attack rate for this might be higher. That is, the contagion might be a little higher. So either you have symptoms or you don't. If you have symptoms, we say you're symptomatic. If you don't, we say you're asymptomatic. Okay? And so when we're talking about the asymptomatic period, or the period without symptoms, we're talking about really the incubation period. So the time from when you get infected to the time that you show symptoms. On average, another overlap between the seasonal flu, on average, that period is between about 2 days and 2 weeks. That's why when we talk about quarantine and isolation, we'll get into that later, folks have to be isolated for 2 weeks because that's the incubation period. And if they don't show symptoms in that 2 weeks, then we think they're out of harm's way. Right. Folks are walking around without symptoms, but that are infected, and they're transmitting it. But you still can transmit it even though you don't have symptoms. All right, so this is central. If you don't test for it, you don't know where it's at. If you don't know where it's at, you don't know how to respond or mitigate to it. We are woefully behind the containment curve because our test kits aren't out there. We don't have the saturation across this country that we need. Give you an example. We've done about 1,900 tests all in from the beginning to now, to today. A place like South Korea quickly got up to 10,000 tests per day. So the more you can test, the more you get your hands on where the problem is. So we're way behind the containment curve because we don't know where it's at, although we know it's community spread, we're way behind. So that's a big problem at this point. What happens quickly is we isolate what the bug is, in this case, the novel coronavirus, and then we begin to develop a test for that. And some of the tests will measure for the antibodies, your immune response to it, or some of it will actually measure for the particles of the bug. Okay. So that's what happens when you're developing it. Typically, it's a swab. They swab your throat or your nose. There can be a blood test as well, and then that's processed. Now, how do you get it? At this point, as our government has released additional tests, and there's more tests going out to states and things like that, you're going to want to request the test from your healthcare provider. That test is actually probably going to be processed in any number of places. So your state and local laboratories. Now, everything I say is changing all the time. So it's going to be refined and modified as we go forward. But the fact is that they're trying to move into commercial labs like Quest Lab and LabCorp and things like that. Academics can test for it. Not enough testing there yet, but that's kind of how it works. First of all, if you can get your hands on a mask, good luck. Because with a combination of price gouging and hoarding, it's hard to find a mask. That said, the good news is you don't need a mask. You don't need a mask unless you actually have the illness, and the mask is really to protect others from you. So as you're walking around talking and coughing, you don't get anybody else infected. Or if you're taking care of a family member, or if you're a healthcare professional, obviously taking care of a patient, then you need one as well. So those are really the only indications for mask at this point. If you have symptoms, you've had some possible exposure, you have some travel history of concern, you call your doctor and you say, hey, I think I might have this. Your doctor, he or she may say, put on a mask while you get here. Let us know ahead of time. And folks should call before showing up. Okay. So first, I'm going to make the point, we never contained anything. Okay. So we were not contained, but we are going to mitigation because containment didn't work. Right. Viruses don't recognize or hit to borders or travel bans. So nothing's been contained, but the mitigation strategies are really bread and butter public health mitigation strategies. It really focuses on due diligence and the honor system of all of us doing our part in it, and things around what we call flu hygiene. And I think if there's one consistent message that everybody from the president on down has really emphasized is the importance of flu hygiene. That's the hand washing. We call it the 3 C's. Clean or wash your hands, cover your cough and nose if you're sneezing or coughing, and then contain yourself, or that is stay at home if you're sick. Those are the basic things to prevent the infection from spreading throughout the community. But we're also talking in terms of things that we call social distancing. Because we know older folks are most at risk, and we know a lot of our older folks going to church is a very important social thing for them, that, we're at the point now where we may need to start thinking or rethinking, maybe doing church online. But the whole social distancing, avoiding crowds, avoiding mass transportation and things, if you can, working remotely and things like that. We'll get into that. And then as we all greeted each other this morning, we did the old L bump, right? Not the elbow, but the L bump and the fist bump. And so we're getting into those things as well because we're trying to do our part with our individual and collective responsibility. So those things are going to continue. I think I know the biggest myth about this is that we're in good shape. We are not in good shape. We are nowhere near being in good shape. We are way behind the containment curve, and we're just trying to get our mitigation act together. So I think that we need to understand, your members need to understand, that we have a long way to go. It's going to get much worse before it gets better because we're undercounting. We don't really know the cases. There's way more cases than we know about. We just got to keep stressing the importance of transparency and honest brokering of, and good solid communication. They say that sunlight is the best disinfectant. And we have to be clear about what we know and what we don't know. So there is a public health enterprise,
Yep.
and it's local, it's the state, and it's the federal, which is CDC.
Uh-huh.
Most people may not know there's over 100 local health departments right here in the state of Illinois, and across the nation is about 60 state, tribal, and territorial health departments. All the things that we've talked about in terms of business preparedness, business drilling, business having the right personnel, labor force, and things like that. The local health departments across the country, there's about 3,000. That has had a deterioration of about 50,000 workers, your labor force, over the last 5 years. So it's contracted.
Right.
The resources aren't there to do the drilling, the plants, and things like that. So who's going to do the vaccination clinics when we're in a situation like that, when we have a vaccine? Who's going to go door to door and monitor the quarantine or the isolation? So it's a great opportunity for the business community, many of the members here, to partner a private-public partnership to make
really
sure your infrastructure for public health is intact so we can handle this. I think sometimes we get so focused in the revenue, the bottom line, the key performance indicators and the like, that we lose sight of the purpose and the people, the end user. So at DLM, we really are in the business of working with businesses to bend the arc of wellness for individuals and for communities. And so keeping that up front, and I think it kind of, this human connectedness during crisis can help to reemphasize that.
Quick.
I'll say fear goes viral much faster than coronavirus, as does misinformation.
Yep.
So I'll get back to the quote that sunlight is the best disinfectant. So now is not the time to be huddling in the C-suite and getting your plan together without communicating on a regular basis to your team.
Perfect.
I'll take it, and I will set kind of expectations. So test is the key. We need to do broader testing, more testing. I would estimate that we should have the capability at every state level to do at least 500 to 1,000 tests per day. That puts us in the range of about 50,000 tests per day. We should be testing that much, because until we test, we won't have the denominator, and that what we'll see is that the more testing we do, that case fatality rate will come down and down and down and down, and we'll be able to put our arms around this epidemic, find the hot spots, and really do more mitigation. So testing is going to be the key. I would also say that people should expect the case counts to go up. They're going to go up really, really high over the next couple of weeks, so just expect it. No need to panic. It just means we're starting to test it appropriately. I would say moving down the continuum from cooperation to coordination to collaboration, as Jim said, because we have to work across jurisdictions, state jurisdiction, across national boundaries, and really, bringing industry in and other partners to collaborate in a true way. Is something that we should get. Yes. I think probably the true rate is probably somewhere between 1% and 2%, but because the denominator is so small, we're not there yet. Great question. So the regular seasonal flu does have a pattern to it. It usually peaks between December and February, and then it kind of tapers off. This is brand new, so all bets are off. We don't know what this is going to do. It may come every year at the same time. It may taper off and be squashed. We don't know. So, but what I can say is that we haven't reached our peak yet in the States. So we got to peak first and then start tapering off with the mitigation strategies. So an estimate, I would say yes. We know it's about 1 to 30. In other words, for every death, there's an estimated 30 people that are infected. So if we were to take our 22 deaths, we would estimate that there's at least 660 folks who have the disease. Right now, we're reporting 545, so we're low. Again, re-emphasizing the fact that we're under testing. So, so that's kind of we can kind of reverse engineer it and understand based on death how many folks we should have in the population right now. Again, there's a lot of folks walking around who were without symptoms or asymptomatic, may have had some direct or indirect exposure and have not gone on to symptoms yet. So it's very important, again, that due diligence from each of us in terms of being accountable and responsible. We got to keep in mind this. It is flu season, So, every year 10% of the population gets the flu. That's 36 million folks. And about, 20 to 50,000 people actually die of the flu every year. So we are in flu season, so that can happen. If you have flu symptoms, you may have the seasonal flu. But obviously, if you're in flu season and you have flu symptoms and you have some contact concern, history, or exposure, then that's going to tip you over to try to be more likely to want to request the coronavirus test. So we're trying to fast track the vaccine development, but some steps you can fast track, some steps you cannot. You have to go through the clinical trial for safety and efficacy, and then you go on to produce it. And so some of the things that can be fast tracked are things like regulatory review or maybe production of it once you get it together, but you can't go faster in terms of the clinical trial because we want to go fast, but we want to go safe. So the estimates are really realistic at 1 year to 18 months, and that's really a fast track. So you just can't leapfrog certain steps and put out a safe vaccine that's going to be useful. I think that it should be an individual decision. I think that if you understand if you're in a high-risk group or a low-risk group, if you're older and you have hypertension or diabetes or asthma, you probably should think twice about going. So you got to kind of do your own kind of risk stratification and then kind of make that decision. So I think that the biggest point of collaboration for the health community is really the cross-national collaboration around vaccine development and countermeasures or medications or immunoglobulin things, treatments for this. And so labs are opening up, industries are opening up, they're cooperating and trying to move faster. So that's probably going to be a good legacy from this.